Drugs. Everyone's had them, some kind of drug, legal or not, and all drugs have some kind of effect on the body. As sleep technologists, we are most interested in the effects drugs have on sleep, as well as the drugs used to get more sleep or less sleep. In Greek, pharmakon loosely means drug or poison, semantically pointing towards violence or death. Ancient civilizations would use a charm to ward off evil spirits that supposedly caused a disease. Breaking down the word pharmacology, you get pharma, meaning drug or chemical, and cology, or the study of. Today, we interpret pharmacology as studying the effects of different substances on the body. There is virtually a limitless variety of characteristics that ultimately determine what the drug will do. First, consider the dosage of the drug. How much do you take and how often? Some drug doses depend on weight and some don't. Next, the route of administration. This means how a patient is exposed to a drug. Is it a pill or a patch or an injection? How much of the substance in the dose is actually used by the body, also known as bioavailability. Not only are drugs different, but people are different. The way people tolerate the process of the substance differs from person to person. The reason there are so many side effects listed for all drugs is because those are all the side effects that everyone has called into the company to say they had a side effect. Not everyone has them, or all of them. Some might not be aware of any. What are the properties of the drug? What's in them? A lot of drugs are in salt or sodium form. So a lot of pills are, where the liquid drug has been dehydrated and left over as concentrated salts, which becomes the active ingredient. Then they're either compressed in tablets or contained in dissolvable capsules. When you introduce more than one drug into the body, those drugs can interact with each other and sometimes amplify the effect or slow the effect down. Think about mixing drugs like alcohol and narcotics. It's a fatal cocktail for central apneas. There are even differences in the way generic drugs and brand name drugs are manufactured. The ingredients may be the same, but the way they source the ingredients and the process of manufacturing and distribution may be different, which can cause the drug to affect the body differently. What's the difference between generic and brand drugs? Brand drugs come out first, and they are the only company that makes the drug if they have a patent, which for drugs the patent lasts 20 years. Typically, you can file the patent, and then it might take 4 or 5 years for the drug to actually come out to market because of all the red tape. So even though you have 20 years, you might only have the drug on sale for 15 because it takes so long to make it, and then you only have 15 years to sell it. Afterwards, generic drugs can be manufactured. Generics are not necessarily made the same, but it has the same ingredients and are usually much cheaper than brands. Some physicians require brands because they are made differently and can work differently. The greatest effects of any drugs are usually dependent by its dosage and how it's processed through the body. Here are some of the common ways people get drugs inside them. They can be inhaled, either nasally or orally, like albuterol inhalers or some nasal inhalant vaccines. Nasal inhalant drugs either bind to the nasal passages, the throat, or the lungs, and oral inhalers reach the bronchioles and the lungs. Intramuscular injections are drugs that are injected with a syringe into a major muscle group. Muscles have good vascular circulation, and the drug is able to enter the bloodstream easily this way. Intraperitoneal injections are injections into the intraperitoneal cavities between the abdomens and the legs, or just on the side of the lower abdomen. Some chemotherapies are directly injected into the abdomen. And we're not talking about the surface either. This is behind the muscle into the abdominal cavity. Intravenous injections involve a syringe and needle directly invading a blood vessel to directly administer a drug into the bloodstream. Subcutaneous injections is a specific kind of needle and syringe that specifically refers to the needle only penetrating just beneath the skin and the fatty tissue. Ozempic and insulin are administered subcutaneously in the intraperitoneal areas. Topical solutions are liquids, creams, powders, or gels that make contact with the skin. And you have good old oral medications, either in pill or liquid suspension form. PO stands for per oral, meaning by way of mouth, or put it in your mouth. A couple other methods of administration includes transcutaneous, like patches, which can be nicotine patches, narcotic patches, or motion sickness patches like scopolamine. Another fascinating way to deliver the drug is by suppository, which means rectally. Many analgesics can be administered this way. There are 4 phases of a drug's interaction with the body. They are absorption, distribution, metabolization, and elimination. A drug must first be absorbed, then distributed into the tissues, metabolized by individual cells, then eventually eliminated from the body in some manner. How are drugs absorbed? Well, it depends on how it is administered. It could be through the lungs for inhalants or the stomach or intestines for oral drugs. How is the substance distributed? Or how does it move through the body before it goes to work? When it gets to its target, how does it perform its action, or how is it metabolized into the body? Finally, the inert ingredients or active ingredients that are not metabolized because bioavailability must be eliminated, like through urine or stool. Because there are many forms of drugs and many ways to administer them, how a drug goes through each of the cycle phases determines how much of a substance is required to reach the desired effect. For instance, morphine may be given in smaller amounts when injected directly into the bloodstream than when swallowed in a pill. Like CPAP, the act of finding the right dosage for a patient is called a titration. Depending on the person, all drugs have an effect on sleep in one way or another. At least half of the top 20 medications prescribed to Americans list the side effects involving sleep. Sleep technologists must be aware of the latest trends in the use and abuse of drugs, as well as be familiar with literature linking medications to altered sleep. Technologists must determine if and how each sleep study might be affected by the patient's medications, including those not taken on the night of the study. Technologists must also pay close attention to the patient's medications and document them in the study. This will greatly aid study interpretation and increase the likelihood of a correct diagnosis. You never know what tiny detail might totally change change diagnosis and treatment. The first class of drug we'll cover are sedatives and hypnotics, which is highly applicable to sleep since they are used to make a patient super calm or sleepy. When taken before bedtime at high doses, it becomes a sleeping pill. When taken at lower doses during the day, the same medication may reduce excessive arousal and act as an anxiolytic. Some anxiolytics are used for sedatives, some are strictly just for anti-anxiety. Here are a few reasons why you may see prescriptions for sedatives or hypnotics. Sedatives and hypnotics can help patients who worry themselves so much that they actually lose sleep over it. They can also put a patient to sleep despite loud noises or environmental disruptions or physical pain. That sounds really nice until the house catches on fire and you sleep through it. So there are some real hazards to consider with patients who take these drugs. They can make you so sleepy while you drive or while you should be otherwise awake, like when you're performing surgery. Barbiturates are a class of sedatives and hypnotics commonly referred to as downers because that's what they do. They put you down in the bed. These are central nervous system inhibitors, which means the nerves don't send as many signals from the body to the brain or vice versa. These can be used for mild sedation or as a general anesthetic, so some sleepiness versus knocking you out. Uh, Obvious side effects would include lethargy, slurred speech, shallow breathing, fatigue, drowsiness, and some difficulty concentrating. Other serious side effects would include significant respiratory depression, which means the brain is saying, it's okay, I don't need to breathe right now. The real fatal problem with barbiturates is the potential for abuse, and it occurs really easily because they are super addictive. A person's tolerance to a drug or how quickly they get used to the effects can change quickly, making an effective dosage higher each time. The barbiturate's addictive property causes high dependence. When you add a highly addictive drug that makes you increase the dosage and then a limit where the certain dosage can kill you, you're going to have a bad time. Judy Garland was Dorothy in 1939 MGM production of The Wizard of Oz, and from a very young age she was addicted to barbiturates to make her sleep at night and stimulants to make her perform during the day. She died early in her 40s due to a barbiturate overdose. Another heavy-duty drug used for the initial sleep onset during surgical anesthesia is propofol. Michael Jackson died from getting propofol as a sleep aid. It had been given to him by his physician. It has to be given in an IV. Elvis Presley was another star that ultimately succumbed to mixing drugs. These substances have an incredible effect on the body and are incredibly addictive, and your tolerance can be, they can develop quickly as well. Other possible side effects include amnesia, cognitive or psychomotor impairment, dependency, exacerbation of sleep apnea because the body's arousal mechanism is inhibited. It can't react to a respiratory event like it normally would. Rebound anxiety with insomnia, reduction of deep sleep, increased presence of sleep spindles in the EEG. Spindles are thought to be a marker of the inhibitory processes keeping the patient asleep. And you may even see something called pseudospindles, which are really long spindles. And finally, you can become tolerant to the drug, making it less effective at the same dosage. These aren't all of the side effects, but it's a good list of what to expect. Here are a popular list of here's a list of popular barbiturates. The brand names come first, and the generic name is in parentheses. We'll talk about the difference of generics and brands later, but for now, try to recognize the suffixes or the endings of these names. Barbiturates usually end in -al or -itol. You may recognize the name sodium pentothal. It's the first drug of 3 for lethal injection inmates, and it relaxes the patient. Sodium pentothal really isn't used anymore because it's really short-acting and it's easy to abuse. It's also been banned in certain places for the express purpose of lethal injection death penalty. Phenobarbital has extensive use as an anti-epileptic drug and in the neonatal and pediatric population. It is most cost-effective treatment for epilepsy in adults in low-resource countries. Intravenous barbiturates have been used for neurosurgery due to reduced cerebral metabolic rate of oxygen consumption, and this is for long-acting purposes. Pentobarbital is a pre-anesthetic medication and status epilepticus, which means a seizure lasting longer than 5 minutes. Pentobarbital is used off-label for traumatic brain injury associated with refractory elevated intracranial pressure, and that would be for short-acting purposes. Refractory elevated intracranial pressure just means when you have an accident and you have a bleed, usually, and that's causing pressure inside the skull because that skull is waterproof and there's nowhere for that extra blood to just go anywhere, so it causes more pressure. Phenobarbital is highly addictive, and patients are susceptible to addiction, overdose, and withdrawal. For sleep, it will decrease REM sleep, decrease sleep latency, increase REM latency, and increase sleep quantity and spindle density. Ultimately, you can expect the same side effects from the same classes of drugs. Barbiturates will decrease sleep latency, wake, after sleep onset, N1 sleep, N3 sleep, REM sleep, arousals, and body movements. They will increase sleep efficiency, total sleep time, N2 sleep, REM latency, sleep apnea, and daytime sleepiness. They are commonly used as a muscle relaxant or a sedative. Barbiturates affect the GABA receptors of the brain. GABA is an amino acid classified as a neurotransmitter that helps induce relaxation and sleep, so GABA is pro-sleep. Benzodiazepines are sedatives that are especially important in the cessation of seizure activity. 1 to 2% of emergency department visits annually in the United States are for seizures, and this is a big one to use. Indications for benzodiazepine administration are linked to, but not limited to, anxiety disorders, insomnia, acute status epilepticus, meaning seizures over 5 minutes transiently, out of nowhere, induction of amnesia, spastic disorders, seizure disorders, agitation. The way they act is it increases GABA receptors so that more GABA is present. This allows more openings for chloride ions to enter the neuron, causing it to hyperpolarize and essentially shut down. As most sedatives and hypnotics do, benzos work by depressing the central nervous system. Side effects may include daytime sleepiness, lightheadedness, headaches, amnesia, and incoordination. Here's a list of brand name benzodiazepines with the brand name first and the generic name second. These drugs have a lot of AMs at the end of the generics, LAMs, or PAMs. I might have talked about it before, but when I was transitioning back to night sleep from day sleep when I was working nights, I was prescribed Xanax for 3 nights to help reset my circadian rhythm. I only took half a pill each time, and it knocked me out really quickly. It was really nice to be able to sleep like that. After the dosages were over, though, I felt like I had the flu. I had pretty bad nausea, chills, shakes, and sweating when I was cold, the whole thing. If I have any say over the matter, I will not use another benzo just because of how awful it was not to take it. And that says something for addiction. I don't have an addiction unless you count coffee or chocolate. But I can certainly see how someone would continue taking it if it stops the withdrawal symptoms. I've personally performed sleep studies on several patients who routinely take 2 pills a night and have been for a long time. It's nice when you need those drugs to work, but they can be awful when you are susceptible to the withdrawals like I was. These are the overall expected sleep effects that benzodiazepines have. They will decrease sleep latency. It'll put you to sleep quicker. It'll decrease how much time you're awake after sleep onset. It will decrease REM sleep, N3 sleep, periodic limb movements, and arousals. They will increase sleep efficiency, total sleep time, N1, N2 sleep, sleep spindles, restless legs, sleep apnea, and daytime sleepiness. There is also an added likelihood of exacerbating sleep-related breathing disorders or hypoventilation due to the central nervous system depression effect it has. You can see a lot of spindles in this epic. This is from a record of a patient who is on benzodiazepines. Here's a bit of spindles. Here's some right here. This looks like a pretty long one. That's all beta activity there. Here's a K complex with a spindle. Spindle, 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 long spindle. Maybe another spindle right there. Tons of them. Benzodiazepines. There are a couple of drugs that are considered sedatives or hypnotics that are not considered benzodiazepines. We call them non-benzodiazepines. They were developed primarily as an alternative to traditional diazepines for the treatment of insomnia. They can do many things that normal benzos do, but they can also be used as certain sedatives. However, non-benzos can be used in surgery. They are used for short-term treatment of insomnia as well. Unlike benzos, non-benzodiazepines have a shorter half-life and are less likely to cause addiction. General side effects include amnesia, erratic behavior. It can exacerbate REM behavior disorder, dizziness, and daytime drowsiness. Sometimes called Z drugs, non-benzodiazepines were created in the 80s and released in the 90s. They work by binding GABA A receptors, causing more GABA to be produced. GABA promotes sleep by inhibiting neurotransmitters. It's like putting the brakes and slowing the CNS, causing sleepiness. Zaloplan is a generic name for Sonata. Like the other sedatives and hypnotics, it acts upon the central nervous system as a depressant. It decreases sleep latency and increases sleep quantity. Interestingly, it has little effect on sleep architecture. Zolpidem, also famously known as Ambien, is a non-benzohypnotic agent that works just like Zaloplan as a GABA inhibitory agent. Benzos open all benzo receptors, which causes the cells to calm down for seizures. Zolpidem only affects BZ1 receptors, which has an absence of the myorelaxant with muscles and anticonvulsants, the seizures. Ambien is typically for short-term treatment of insomnia, but I've encountered many patients who just use Ambien all the time and have for a long time, just like benzos. I've also seen people who take Ambien and keep themselves awake, which will cause them to hallucinate. With most people, Ambien decreases sleep latency, increases sleep quantity, N3 sleep, and N2 sleep. Azopiclone. These drug names are hard sometimes. Azopiclone. Lunesta is the brand name for azopiclone, which works the same as other non-benzos, essentially the same as Zopiclone. There are several reasons why different named drugs do work the same way. Although they do the same thing doesn't mean that they do the same thing in the same way. They may have different active ingredients or are made with different processes. Different drugs might be the same thing, but the name has to be changed so they can apply to different off-label treatments to be considered not an off-label treatment. Ramelteon, wow. Ramelteon works as a melatonin agonist. Melatonin, as we know, is a sleep-inducing chemical. Rosarem increases production of melatonin in the pineal gland when given the signal by the suprachiasmatic nucleus. So if the SCN lights a small fire in the pineal gland to produce melatonin, Ramelteon brings gasoline to increase production. It is likely to decrease sleep latency, increase sleep quantity, and fortunately really not have any other effect on sleep. Xyrem is the big daddy of them all. Also known as sodium oxybate, Xyrem is one of the most effective drugs at putting someone to sleep. It's made from the sodium salt of gamma hydroxybutyrate, or GHB. You might have heard of that. It's the classic chemical compound for date rape drugs. Xyrem works by stimulating GABA receptors. Patients must be enrolled in the drugs manufacturer's risk evaluation and mitigation program. A central pharmacy will only dispense to patients enrolled in the REMS program. They have to be counseled on the risks and proper use of sodium oxybate. There are obvious risks. If there's an emergency, there's a great chance the patient will not be able to respond. Some side effects include nausea, insomnia, headaches, urinary incontinence, dizziness, vomiting, weight loss, psychiatric complications, and sleep apnea. Chlorohydrate was an oral sedation agent used mostly in pediatric patients and dentists, but it was also used as a short-term solution for insomnia. Like sodium oxybate, which is based off of GHB, it was popularly used as a date rape drug. Street names for chlorohydrate include Mickey Finn and knockout drops. Luckily, it is detectable in alcohol due to its bitter taste when mixed. Currently, it is not manufactured for medical process purposes due to its narrow range of usage. It is noted to decrease REM and sleep latency as well as increase sleep quantity. Why are we talking about a drug that we don't even use anymore? Because some patients may get their hands on it. Also, it might still be on the BRPT. Sometimes they don't take these drugs off for a while. Overall, non-benzodiazepines are expected to decrease sleep latency, decrease wake after sleep onset, N1 sleep, and REM sleep. It should increase sleep efficiency, total sleep time, N2 sleep, and REM latency. Belsomra, also known by its generic name suvorexant, is an orexin receptor antagonist and can be used to treat insomnia. One of the main differences in functionality of Belsomra versus Ambien is that Belsomra works for 8 hours while Ambien loses its potency in just a few hours. They are both central nervous system depressants, but Belsomra is an orexin receptor antagonist instead of a GABA inhibitor, meaning it blocks orexin receptors with its own chemicals. That seems backwards, right? Orexin is a sleep-promoting chemical, so wouldn't you want to receive more of it? When you block the receptors of sleep chemicals, those chemicals continue to be produced until the body's desired effect occurs, which is usually sleep. All of a sudden, the receptors are flooded with orexin and the patient goes right out, usually. This takes some time, but not more than half an hour, which is why it's important to take it just before bedtime and not an hour or two before. Staying awake while using sedatives or hypnotics can cause the opposite effect, and you make it into a stimulant. You can expect Belsomra to decrease sleep latency and wake after sleep onset, but increase total sleep time, sleep efficiency, and REM quantity and density. Possible side effects include residual daytime sleepiness, including impaired performance and drowsiness. Alcohol is one of the most frequently used substances to help someone go to sleep. If a person uses too much, they can become tolerant to the effects, causing them to need more. It can also make a person dependent upon alcohol to fall asleep if they don't have enough or any at all. Alcoholism, the disease that makes a person dependent upon alcohol to function at a minimal level, has serious withdrawal effects, including life-threatening seizures. Alcohol is mainly a CNS depressant, but it can also give rise to stimulating effects. Because of its addiction and dependence characteristics, as well as its propensity to cause cirrhosis of the liver and fatty liver disease, patients should be cautioned against the use of alcohol as a sleep aid. Alcohol may cause excessive urination and, in large quantities, be fatal. If you're running a sleep study and a person is an alcoholic or uses alcohol as a sleep aid, they should bring some in to the sleep study because it will change the results. In large doses, alcohol is a depressant. In small doses, it can be a stimulant. Acute ingestion, or just when you ingest alcohol on occasion or rarely, you can expect increased N3 sleep, decreased sleep latency, and decreased REM sleep with REM rebound upon withdrawal. The final third of the sleep time is disrupted. Chronic alcohol ingestion will reduce sleep quantity and continuity. It will also decrease REM and cause REM rebound upon withdrawal, or once the patient becomes naturally sober. When alcoholics sleep sober, they have a prolonged sleep latency, increased fragmentation, and a shortened total sleep time. These symptoms can persist up to 2 years of abstaining from using alcohol. It all just depends on the person and how much they've used and for how long. Alcohol's overall effects on sleep include increased wakefulness, sleep fragmentation, non-REM sleep, apnea duration, and AHI. Apnea duration and AHI are most likely due to the inhibited arousal mechanism in the CNS, which has been depressed. The apneas can be longer, and the airway muscles are probably more relaxed, allowing more events to happen. Alcohol will decrease sleep latency and also REM sleep. That's why it's so important for them to have it while they're in the sleep lab. Physicians need to exercise extreme caution when prescribing sleep aids like barbiturates, benzodiazepines, or other central nervous system depressants. Sleep aids are really supposed to be used on a short-term basis for sleep-onset insomnia and or sleep maintenance. Sleep-onset insomnia means you just can't fall asleep, and sleep maintenance means staying asleep. Sleep aids should be chosen based on the patient's specific symptoms, their sleep patterns, their underlying conditions or comorbidities, and the dynamics of how the medications work, or how long it takes them to work, or the onset of the action, the duration of the action, or what we might call the half-life. The half-life is the duration of the substance's efficacy. Efficacy. Man, I'm having trouble with words today. That's when the substance's potency has been reduced to 50%, which largely depends on how the body metabolizes and eliminates a substance. That's enough for now. That's one of 4 drug slides for the presentation. So, drugs have a big deal. They are a big deal in sleep. They can really help or hinder your sleep, and usually it's not one or the other. It's a combination of both. So, I'll see you again next time for more drugs.